Welcome everyone. This is Ann Priest. I am a registered dietitian and manager medical scientific liaison at Nestle Health Science. I will be moderating today's presentation entitled Nutritional Implications for Transplant Patients. Financial support for this presentation was provided by Nestle Health Science. The views expressed are those of the presenter and do not necessarily represent Nestle's views. The material is accurate as of the date it was presented and is for educational purposes only and not intended as a substitute for medical advice. I am very pleased to present today's speakers, Dr. Jeanette Hasse and Michelle Kozinecki. Dr. Jeanette Hasse has worked in the critical care nutrition field for over 35 years and has worked full-time with transplant patients since 1986. She has been involved in related research and development of nutrition care protocols and currently manages a team of transplant dietitians. Jeanette has given many professional presentations and has several publications on nutrition and transplantation. Dr. Hasse is the editor-in-chief of the journal Nutrition and Clinical Practice. She has received several professional awards. Jeanette received her BS degree in nutrition at the University of Nebraska and received her MS and PhD degrees in nutrition at Texas Women's University. Michelle Kozinecki, our next speaker, is the lead clinical dietitian at Froedtert Hospital in Milwaukee, Wisconsin. She is a certified nutrition support dietitian and certified clinical transplant dietitian, and has over 10 years of experience in nutrition support and critical care nutrition. She joined the Transplant ICU interdisciplinary team in 2016. She is an active member of several ASPEN committees, past president of WISPEN, and an NFPE trainer with the Academy of Nutrition and Dietetics. Her main interests involve around enteral feeding during hemodynamic instability, nutrition and end-stage liver disease, disease-related malnutrition, and micronutrient deficiency, and she has published over a dozen peer-reviewed articles on these topics. Here are the speakers' disclosures. The objectives of this program today include discussing malnutrition assessment and transplantation, analyzing body composition technology and its role in transplantation, reviewing micronutrient assessment, risk factors for deficiency, GI losses, and disorders of metabolism, and finally discussing recommendations for replacement of certain micronutrients while receiving therapies such as the RRT. And now I would like to hand it over to Dr. Hasse.
Thank you, Ann. It's my pleasure to be here with you guys today and to give you some of my perspectives on nutrition assessment and body composition and maybe how we can use that in our clinical practice. So I think we need to kind of level set and say, why do we even care about nutrition status and transplant? So if we look over here on the right-hand side, this top graph is showing us that the number of transplants are going up. It's also showing us that the wait list is also going up. But what we see is that there's a gap between the number of patients getting transplanted and those wanting to be transplanted. And we know that nutrition assessment or nutrition status of our patients affects their transplant candidacy and what their outcomes are going to be. And in this use of a limited resource such as transplant, it behooves us as dietitians and healthcare professionals to identify the patients who are at nutrition risk and try to implement some outcomes to improve their outcomes after transplantation. So I want to talk about these three terms because they tend to overlap: malnutrition, sarcopenia, and frailty. And malnutrition just kind of means poor nutrition, whether that's overnutrition, undernutrition, macro deficiencies, or Michelle's going to talk about microdeficiencies, micronutrient deficiencies. We also use these terms sarcopenia, and a lot of times the literature, we talk about sarcopenia in terms of muscle loss, but it's also loss of muscle quality, not just the quantity, but the quality. And then we're not going to necessarily talk about frailty today, but it kind of interlocks with all of these concepts in that patients who are malnourished tend to have low muscle mass and tend to be frail. And we know all three of these things affect our nutrition plan and affect the patient's outcome. So when we're looking at nutrition assessment, what we really want, the holy grail, so to speak, is that we want to have some type of objective marker that is valid, that it's reliable, that it's sensitive. It'll tell us what we need to know. It doesn't matter who does the test, and it's going to show changes over just a short period of time. We also want that assessment to be easy to use, safe, affordable, and available, that we can do it time after time. And we would really like to know if there's some kind of easier way for us to be able to measure body composition and what effect that might have on transplant. So I think most of us are comfortable, especially with like subjective global assessment. I'm going to talk a little bit about that. I am going to spend most of the time talking about body composition. Michelle's going to talk about micronutrient status, and we don't have time again today, but frailty kind of falls into that as well. So let me give you my perspective on doing a subjective global assessment for a patient. The first thing I do is I want to look at their medical history. What is their underlying disease? Because I already know that some things are at higher risk for malnutrition. So let's take, for instance, cholestatic liver disease. People with PBC and PSC are going to have more micronutrient deficiencies, probably fat losses, more osteoporosis. Somebody with cystic fibrosis getting a lung transplant, we already know that those patients are nutritionally at risk. I also want to know the duration and the stage of organ failure. Is it a patient who has end-stage liver disease and decompensated cirrhosis with these other complications, or is it somebody who might have cirrhosis, but the reason they're getting a transplant is because they have a tumor? The same thing with chronic kidney disease. Are they post-dialysis? Are they pre-dialysis? And what complications of organ failure do they have? Do they have hyperkalemia, hyperphosphatemia? Do they have ascites? Do they have early satiety, GI bleeding? And what other comorbidities do they have? So for example, if I have a patient who is getting a liver transplant from alcoholic liver disease, does that person also have chronic pancreatitis? Does my patient have diabetes, and what is the control of their diabetes? And then also, what kinds of surgeries have they had in the past? And here I want to specifically mention bariatric surgery, because we see a lot of times these patients coming in for transplant have had bariatric surgery in the past, and now they're malnourished, and they may not have been taking vitamin supplements, and we know that there's going to be micronutrient deficiencies as well. I think we can't overstate the importance of getting a measured height. We've really worked with our clinic staff to be able to measure height without the shoes if it's safe for the patients. What I like to ask about weight was, what was your weight before you got sick? So that kind of level sets me to what their body type was, and maybe what their usual weight was before they had whatever chronic disease they have. And then looking at the high and the low weight, since most of the organ failures cause fluid retention. And I kind of use that low weight as kind of my estimated dry weight or actual weight in those patients. We all know that we need to get a thorough history from our patients, and I can't underscore the importance of getting a diet history to not only find out the quantity of what they're eating, but the quality, and if they need to be restricting any things because they have, of course, fluid retention, any other dietary habits, maybe even things like celiac disease, or they follow a vegan diet. The other GI symptoms that we're looking here are either appetite, nausea, vomiting, diarrhea, and constipation. These are really more important if they've been going on for a long period of time. So if you look at the original SGA tool, it talks about being whether it was greater than 1 week or greater than 2 weeks. It really doesn't affect their nutrition status that much if they had nausea, vomiting, or diarrhea one time last week. But if it's something that's ongoing, then that's important. I also think in the times here of COVID, not only asking about chewing and swallowing, but if the patient has had COVID, do they have any problems with taste or smell? Michelle does a lot of this nutrition-focused physical exam training, and I just want to point out that in your transplant patients, this is where you can see some of the most severe consequences of malnutrition in your physical exam. So if you look up here, you can see the orbital fat pad loss and the temporal wasting. You can see the severe muscle wasting and maybe even a little bit of edema here. Again, the muscle wasting is very apparent with the bony prominences, the thin arms, the ascites, clubbing of the fingers. So it's very important to do a nutrition-focused physical exam of your transplant patient. I want to just present a couple of cases looking at using subjective global assessment, maybe some nutrition-focused physical examination. So this first patient is 47 years old. She has non-alcoholic steatohepatitis cirrhosis. Her symptoms of end-stage liver disease include ascites, edema, hepatic encephalopathy. She has a past medical history of obesity and diabetes, but since she's lost weight, she doesn't require insulin anymore. You can see she's on diuretics and Neurontin. So when I looked at her more closely, she usually is about 190 pounds before she got sick with the liver disease. She's 5'5½", and in the previous 6 months, she's weighed as much as 174, which is still below her usual body weight, but as low as 126 pounds. And you can see why, because she had a poor appetite, she had diarrhea, she had nausea, she had early satiety, all of the things that would decrease the person's intake. My overall impression when I first see her, she's malnourished, she appears frail, she's got temporal wasting, orbital fat pad loss, prominent clavicle and acromion process. She's got severe ascites, and when you get more history, she's getting her ascites tapped every week as much as 7 liters. Her skin has become very loose because she's got a lot of muscle mass loss. She's got 2+ edema, and of course she's jaundiced and has flaky skin. In our transplant clinic, when we have patients being evaluated for transplant, a liver frailty index is performed on each of them, and this person was found to be frail. So the significance of this in this patient right here, the first patient was such that we said the patient is too malnourished and too frail to be listed for transplant. So she was deferred, and a aggressive nutrition and physical therapy plan was worked with her, and she has improved and is active on the transplant list now. So this patient was a 35-year-old male who had overlap of primary sclerosing cholangitis and autoimmune hepatitis. His symptoms of end-stage liver disease were portal hypertension with bleeding from esophageal varices. He had had a stent placed. Also important to know that he has ulcerative colitis, which about 80% of people with PSC are going to have either ulcerative colitis or Crohn's disease. No history of diabetes, and most of his treatment was around his autoimmune disease or his ulcerative colitis. When I took a history from him, you can see he's not a very large person. He's 5'9", usual weight's about 145. He had weight up to as high as 153, but also as low as 120 pounds. He still had a good appetite, but he had some early satiety, and the diarrhea was probably related to his ulcerative colitis. When I looked at what signs of malnutrition were apparent, they weren't as apparent in this case as the last one. He was still active. He didn't really appear chronically ill. He did have a little bit of muscle loss, but no ascites. And so we really considered him moderately malnourished. What was interesting was that later he had complications after his transplant, which caused him to have worse intake, increased inflammation, more losses, and he actually became severely malnourished before he improved again. So the problem is that when we look at these patients and we do something like subjective global assessment or a physical examination, we can see changes, but we can't see slight changes over short periods of time. And sometimes when you look on the outside doesn't look like it does on the inside, and that's why body composition measurements could be helpful. I want us to remember to not throw the baby out with the bathwater. Heights and weights are still important, if for nothing else, but to find out what they're doing with their fluid status. But also there are studies that show that things like mid-arm muscle circumference are linked to outcomes, and it's something that we can do that's very low cost to measure in our patients. There is problems with inter-rater reliability. For example, if I were to measure it and another staff member were to measure it, we might see differences. But if I see the patient time after time and I repeat those measurements, what we're looking for is a trend. But really, I want to focus on these next 5 technologies that we can use for body composition and kind of talk a little bit about how you do it, what are the pros and cons, and maybe how it would be applied in transplant. So we're going to start with DEXA, or dual energy X-ray absorptiometry. And you can see in the photo on the left that the woman is undergoing a DEXA test. And with this test, there's really these low radiation X-rays of 2 different photon energy levels that are passed through the body. And then they're measuring the energy absorbed or the attenuation. So you can measure fat mass, lean mass, and body cell mass. And that soft tissue is again divided into fat and lean soft tissue. A couple of things of note with DEXA scans, it's going to assume that the hydration of fat-free tissue remains constant at about 73%. So fat mass can vary with severe overhydration. In other words, there's going to be about a 1% change in fat mass with every 5% change in hydration. And it's also recommended that patients should be measured when fasting. You can get several measurements from a DEXA scan, and I'm going to walk through these. At the very top here, you see the appendicular skeletal muscle mass, and these are the cutoffs that are considered low muscle mass, males less than 20 kilograms and females less than 15 kilograms. The appendicular skeletal muscle mass index actually corrects this based on height. So for male, it would be less than 7 kilograms per meter squared in height. And females, the cutoff for low muscle mass would be less than 6. A DEXA can also show you the total fat mass index, so the fat mass divided by height in meters squared. It can also show you this android-gynode ratio, which is similar to a waist to hip ratio. And then some software, more recent software, can actually determine visceral adipose tissue. And the way it does this is it measures the total fat mass in that android region, subtracts the subcutaneous adipose tissue, and that gives you the visceral adipose tissue. The reason that this is helpful is that the visceral tissue is a better predictor of mortality than subcutaneous fat or even the AG ratio. So here's an example of a report. This was several years ago, in fact, a long time ago if you look at the dates. But what I wanted to show you here is this is a male. He was pretty low BMI on the thin side, and he was having difficulties with eating, and it had to do a lot with, he was a status post allo islet transplant patient. And you could see that his body fat was not high to start out with, but it dropped over a period of time. There are newer types of DEXA scans and reports. On this one, it's showing you the blue is the bone or the skeletal mass. The red is the lean tissue, and then the yellow is the fat tissue. So this picture here is going to illustrate how it can look the same and look different in two different individuals. So you can see that both of them have the skeletal. You see the blue, you see the red, the muscle mass. But what you notice right away is that this person right here has on the left has very little subcutaneous fat in yellow, and this person over here has a lot more. If we look down here at the appendicular skeletal muscle mass index, you can see that both of them have low levels, suggesting that they both have low muscle mass. However, if you look at the fat mass index, the patient on the left has a very low fat mass index, and the person on the right has a high fat mass index. So as you can see over here in the figure legend is saying that the person on the left was a young man who had muscular dystrophy, and he had a skeletal muscle mass index of 5.3. And again, the normal for men would be greater than 7 with a very low fat mass. The person on the right was a female who also had low skeletal muscle mass index, but she had a high fat mass index suggesting sarcopenic obesity. So with DEXA, there are some pros, and those would be that it can differentiate fat, lean, and bone. It can also, we didn't talk about how you can look at some segmental issues like the arms or the legs. It's safe, it's non-invasive, it does have good precision and accuracy and can scan a broad range of rates. The radiation is low, and then also this new software can look at other measures such as the visceral adipose tissue. The cons are it's not portable. It still has a fairly high cost. There are differences by the manufacturer and the software that's being used, and it can be influenced by tissue thickness, patient size, and hydration. Of course, it wouldn't be safe for pregnant women. ASPEC has a clinical guideline, and in that guideline, it says that DEXA does appear to be a valid method to measure fat mass, but not necessarily at this point. They can't recommend it for looking at lean mass. The next one I want to talk about is CT scans, and I think at least in liver transplant, we kind of see this has been kind of the gold standard of looking at muscle index. So as you know, a CT scan is just doing cross-sectional images, and that's represented by a 2D map of pixels. Each type of tissue has its own electron density, and you can see that in the color, from the white being the most dense to the black the least dense, and those are measured by Hounsfield units that I'll show you here in a minute. So in this picture here, they have used special software with someone who's trained in how to use the software to look at the L3 or the third lumbar area on the CT scan, and then has used the software to be able to determine what is fat mass and what is muscle mass. So if you were to see these people from the outside, they probably look about the same, but what we see on the inside, they both have quite a bit of subcutaneous fat here in the blue. The red area is the skeletal muscle mass, and you can see the person on the right has a lot more skeletal muscle than the person on the left. The other thing about the person on the left is there's this green inside of the muscle, and that is the fat, intramuscular fat tissue within the muscle. So it's showing that this person has not only low quantity of muscle, but low quality because there's this fat within the muscle. Then the yellow showing the visceral fat. And again, remember we talked about how high amounts of visceral fat are portend for poor outcomes than subcutaneous fat. So we also know that if you look at somebody who is very low body weight or low BMI, there's about 100% prevalence of sarcopenia or low muscle mass in those people. But what we don't see necessarily from the outside is that when you look at patients who have a BMI of 30, even greater than 40, when they have liver disease, over 50% of them also have low muscle mass. So for each different type of disease state, you need to come up with some cutoffs for what would be considered low muscle mass or sarcopenia. These are the cutoffs that were determined for patients with cirrhosis. And again, it depends on whether they're male or female, and they're adjusted for the height. So you probably aren't going to have access to that type of software, and it takes a lot of training to be able to do it. But I just want to show you that you can look at your own CT scans and kind of get an idea. So you just have someone show you how you can get to that L3 level. So if I just look at these two patients, I can see here that both of them have small muscle areas, so they both have muscle loss. The difference is this person on the right has very little subcutaneous fat, and this person on the right has a lot of subcutaneous fat. So this was actually a woman who was really kind of resistant to trying to increase her intake. I actually just show her this picture to show her that you don't have a lot of muscle mass, that's what we're aiming for, is to give you more protein to improve that. So with CTs, there are pros. Again, it's very accurate quantitatively as well as qualitatively. There's high image resolution and consistency between scans. It's useful if you're already having a CT being done, and there are some validated cutoffs. The problems are it's costly. You have to have this special software and the special training. You're relying on convenient sampling. You're not going to just do this to get nutrition information. The patient also has a high radiation exposure. You can't just do this at the bedside and over. And there could be some patient populations, whether it's morbidly obese or very edematous, that may affect the results of these tests. Just briefly with MRI, it's basically the same principles of a CT scan, where it can be measured so they can document the amount of subcutaneous fat, the amount of skeletal muscle mass here in red, the visceral fat is in yellow. The green is, again, that intramuscular adipose tissue, and then the gray is kind of the residual tissues or organs. The pros with MRI are like CT scan. It's accurate, you get good images, it's safe because you don't have the radiation, but again, it's very costly, it's not mobile. You have to have specialized settings, the patients have to hold their breath, and it may not work always for the morbidly obese patient. The next thing we want to talk about is ultrasound, because there's been some interest at looking at ultrasound. And the idea is that ultrasound is going to give an image based on amplitude of reflected high frequency sound waves and the speed at which they travel through the body. And it's usually measured at the quadricep level, maximally compressing those tissues. So here's a picture and an illustration of where that would be done. here on the quadricep muscle. There are pros because there's no radiation, it's portable. We have ultrasound machines on our floor. In our clinic, the access would be easy. And it's believed that it could measure the quality and quantity of muscle. The problem is that there's not really consensus protocol. It's not validated in patients. It needs further examination with edema. There's a lack of cutoff point. So at this point, it's really not recommended, especially in our transplant patients then. The last thing I want to mention then is the bioelectrical impedance. And with bioelectrical impedance, the idea here is that muscle is a good conductor. So there's going to be low resistance. Fat is a good insulator. So there's going to be low resistance. And when you connect electrodes to the patient, usually on the hands and the feet, it gives a very small current through the body, and it can measure the high and the low resistive areas and determine what's total body water, extracellular water, and get the intracellular water and then interpret lean versus fat mass. So single frequency bioelectrical impedance is probably the most common, and it can be either hooked with electrodes on the hands and the feet, or there are some devices where the patients can stand and then they hold onto a bar or another device in their hands where the small current is run through the patient. It's usually a current at 50 kilohertz. With the single frequency BIA, and even with the multi-frequency that we're going to talk about in a minute, they use these regression-derived equations that were developed in specific populations. And those populations were usually healthy, normal weight, ambulatory individuals. So they may not always work in our patients with different ethnic backgrounds, different disease states, different fluid. With multi-frequency, it uses a tetrapolar electrode placement, so hands, wrist, foot, ankle. And again, they can be some standing devices. They apply current at several frequencies, usually at a low frequency at 5 kilohertz, and then at other higher frequencies such as 50, 100, or 200. This enables the device to be able to differentiate better between intracellular and extracellular water, and can also measure different body compartments. BIA is portable, it's safe, it can be reproducible, especially in healthy people, and it's low cost. The cons are it relies on population-specific equations where hydration is set at 73%, and we know that's not necessarily true with our patients. It can be influenced by higher BMI, fluid, fever, electrolyte disturbances, and like DEXA, fat-free mass can be overestimated with extracellular water expansion. BIS, or bioimpedance spectroscopy, is similar, but instead of using these equations, it actually has a program that models within the software that uses this Cole-Haan modeling to determine the extracellular and intracellular water. And instead of measuring at 1 or 7 frequencies, it measures at 50 different frequencies. So the advantages is it can measure impedance over a wide range of frequencies. It doesn't depend as much on these population-specific equations. So hopefully you can get more direct and individualized measure of these body compartments. So this is an example of the ones that I'm familiar with. The one on the right is using the electrodes on the hands and the feet. The one on the left, the patient is standing on a platform with their hands on another electrical platform at the top. This can be done also when the patient is seated, and you can move the hand area down where the patients can reach it. But what we found is that the pressure on the foot plates has to still be significant when someone is sitting down, or you don't get good results. So remember I said it uses this Cole-Haan modeling. Well, this is what a Cole plot would look like. So when we're doing these tests, it's going to show here on the left, this test, what we got measured is matching the fitted curve, and it's of high quality. This one's only of medium quality because the plots that are generated do not necessarily fit as well on that fitted curve. And we want to see these high quality plots. And sometimes you can remeasure the patient and make a couple of changes and get that high quality so that you know you're getting a good measurement. What these BIS reports will show you is you can see fat mass and fat-free mass, and these two added together would be 100%. and it can also give you information about skeletal muscle. It can also give you this measurement called the phase angle, and I want to spend a little bit of time talking about the phase angle. So phase angle is really kind of telling you how healthy your cells are. So at a high phase angle, there's going to be more intact cell membranes and a higher body cell mass. And with low phase angle, there's more cell loss and a decreased cell integrity. So in other words, on this graph, the higher the phase angle, probably the healthier the tissues. The lower the phase angle, there tends to be less healthy tissues. So with different types of disease states, whether it's cancer or surgery, or in this case, liver disease, there have been some cutoff points determined. So in liver disease, the idea is that if you have a phase angle less than 5.4 for women or less than 5.6 for men, that may be associated with poorer outcomes. This is a study that's in press, and I just wanted to mention it because it was looking at phase angle in sarcopenia and cirrhosis and comparing phase angle to CT scans. So what they show here is they had 136 patients. They did CT scans at the L3 level and determined a skeletal muscle index. They also did bioelectrical impedance and got a phase angle. And what they found is that the skeletal muscle index was about 94% sensitive when looking at the phase angle at these cutoff points. And what they're showing is that you have high resistance when you have a high muscle amount, and you have poor muscle mass, you're going to have low resistance, and you're going to see this difference in this phase angle. The study also looked at skeletal muscle mass by CT scan, and again showed that when there was low skeletal muscle mass, there was reduced survival. They basically saw the same curve when they used those cutoffs for the phase angle. So this may be something that we'll be able to use and judge to determine nutrition risk in our patients. Lastly, I just wanted to bring up, this is a poster that's going to be presented at an upcoming meeting. And what we're looking at is we want to make sure that when we're measuring patients looking at BIS, specifically before paracentesis and after paracentesis, to see if there's a difference based on fluid, what differences we see, and if this is indeed a valid test. And what we're focusing really on is this phase angle. That is there enough difference between pre and post that is not going to be valid? Or if it is valid, is this that measure that maybe we can use over time to judge the progress of our patients as they undergo nutrition therapy and physical therapy? So really, in summary, it's very important we do nutrition assessment on our patients because we want to find those patients at risk and intervene to improve their transplant outcomes. We wished every tool that we had was reliable, valid, and sensitive, as well as safe, affordable, and something that we could do easily on a repeated basis over time. I think body composition measures give us another way to look at our patients. Some of them are very accurate, like CT scans, but they're not something that's low cost or something we can do on a repeated basis. So we keep looking for what that measurement might be, whether it's going to be phase angle or something else, as we continue to do research in this area. So I appreciate your time.
Thank you so much, Jeanette, for that talk. I'm going to move on and talk about the nutritional implications for transplant patients, focusing on micronutrients. So just a little bit of background. I don't think this is news to anybody or new information, but micronutrients are vitamins and minerals in amounts in the diet, and they are required for a variety of functions, including growth and metabolism and cellular integrity, as well as functioning in virtually every enzymatic system in the body. So these are essential for metabolism and the utilization of macronutrients, and failure to take in adequate micronutrients can result in deficiency, which has quite a significant amount of implications, including metabolic dysfunction and, of course, death if it gets severe enough. One of the things that I always think about when I'm thinking about micronutrient deficiency and working up my patients, I guess any patient that I see really, is what are the different etiologies of micronutrient deficiency? So where are my risk factors? I've kind of laid them out in 4 different categories here. So the important thing with this, though, is that you're not going to see clinical and functional changes right away. There are biochemical changes that are occurring before those clinical and functional changes are evident. And we'll talk about some of those when we get into the physical exam part of the talk. But these are the risk factors that I always keep in the back of my head. So patients who are not taking enough of the micronutrient. So it's important to get a complete diet history and talk about the different varieties of fruits and vegetables and foods that they're including in their diet. For patients who are in nutrition support, specifically parenteral nutrition, if you have any patients on that, I know in my career, I've experienced a shortage of almost every single product from a parenteral nutrition standpoint, including multivitamin infusion or trace elements. And those are important shortages to keep in mind because you have to then monitor a little bit more closely for deficiency. And for patients who are requiring enteral nutrition, if their volume is insufficient to meet vitamin and mineral needs, those are patients that you're going to want to supplement in addition to meet their needs. Malabsorption is another risk factor for deficiency. So patients with short bowel syndrome, surgical alteration of their GI tract, are automatically patients I'm thinking, okay, they're at risk for micronutrient deficiency as well as protein calorie malnutrition. But then patients with inflammatory bowel disease, pancreatic exocrine dysfunction, and liver dysfunction who aren't able to absorb nutrients, specifically fat in many cases, are going to be at risk for fat-soluble vitamin deficiency as well as other micronutrient deficiencies. Increased requirements or excessive losses. So you can see a lot of therapies included on this list. So dialysis, diuretics, smoking is something that increases needs for vitamin C, for example. So any kind of therapy or symptom like diarrhea or high ostomy output that you're going to have excessive losses for, I'm thinking not only calorie and protein, hydration, but also micronutrient. And then there's also drug nutrient or nutrient-nutrient interactions. So if you're having excessive intake of one nutrient, that can interfere with absorption of another. A great example is zinc and copper. So if you're doing excessive zinc supplementation, those compete for absorption sites. So copper deficiency is something that you then have to be aware of. And then certain medications can interfere with micronutrient absorption. I think of methotrexate as a great example that interferes with the absorption of folic acid. So being familiar with your patient's disease states and therapies and medications and those implications on micronutrients is going to be really important as you do this workup. So I'm going to start with a case and kind of bring this case throughout the presentation. This is a patient that I had, so I'll kind of walk you through my thought process. This was a 64-year-old male with end-stage liver disease secondary to alcohol use who presented to the hospital with fever and chills, and he was found to have elevated liver function tests and acute kidney injury and lactic acidosis. He was unable to provide intake history due to altered mental status, encephalopathy. An example of this is that he stated he ordered soup for lunch, but it never came, and the nurse did have to remind him that the soup was on his bedside table. So we were not going to get any reliable nutrition intake history from this patient. He had moderate ascites, and he was unable to provide a clear weight history. So already I'm kind of at a shortfall from an intake and weight history standpoint. Reviewing his medications, this patient was on lactulose 3 times a day. So some of the things that I'm thinking from a micronutrient standpoint are where are my risk factors and which micronutrient should I be concerned about? So we'll kind of walk through the different risk factors specifically in transplant patients. And this is applicable to patients awaiting heart transplant, liver, lung, or kidney transplant as a result of their end-stage organ failure. Many of these patients have a loss of appetite, so already at risk for inadequate intake. Patients have early satiety as a result of gastroparesis, sometimes from diabetes, sometimes from medications. Early satiety from ascites, that's a very full feeling in the abdomen. You can see in this picture here, and I hear a lot of the times I don't feel like eating, I don't have an appetite, I'll get 3 bites in and I just can't do anymore. And then for patients awaiting lung transplant, for example, but if they're having any kind of breathing difficulties, increased work of breathing can make eating very difficult as well. Patients do complain of taste changes secondary to uremia or possibly as a side effect of medications. And then you also see potentially this circular, it's kind of a cycle of micronutrient deficiency causing taste changes, which cause micronutrient deficiency because of inadequate intake. So it's kind of a vicious cycle there. You can see that with hypomagnesemia as well. Patients with deconditioning might have an inability to either obtain or prepare food. This is mostly applicable to patients in the home setting, so patients that you might be seeing in clinic. And then patients on restricted diets, both at home and in the hospital setting, if they're on a sodium and potassium restriction, as well as say they have dysphagia or other limitations, those restricted diets can really impact their ability to take in adequate micronutrients, as well as calories and protein. And that sometimes decreases the palatability of perhaps a diet that they're used to eating at home without restrictions. So I'm just going to go through the different organ failures here briefly. So the risk factors for patients with renal failure specifically kind of surround the vitamin D, calcium, and anemias. So these are the micronutrients that I have in my mind when I'm assessing a patient with renal failure awaiting kidney transplant. One of the things that I wanted to point out from a micronutrient standpoint is that vitamin A levels are typically increased and the excretion of magnesium and zinc is typically decreased in your pre-dialysis patients. So for these renal failure patients, correction of individual nutrient deficiencies is typically recommended when you have a suspected or confirmed deficiency, but otherwise providing daily needs is the recommendation. These patients may or may not be on dialysis as well as they await transplant. Most of them are at this point, so that is another risk factor that I'm going to touch on another slide. Patients with pulmonary disease, again, providing the DRI initially is the recommendation for micronutrient needs in pulmonary disease, and then correcting individual nutrient deficiencies as they are suspected or confirmed. And then you have another subcategory of patients potentially awaiting lung transplant, and those are your patients with cystic fibrosis. These patients, if they are exocrine pancreatic insufficient, that increases their risk of not only fat malabsorption, but fat-soluble vitamin malabsorption. Typically, these patients are on high-dose fat-soluble vitamin supplements. Patients with liver disease. These are the patients that I work with typically. I work with many of our end-stage liver disease patients in our liver transplant ICU. So automatically I'm thinking, okay, what does your liver do and how is that related to micronutrient status? Well, your liver is involved in pretty much every step of micronutrient metabolism. So it synthesizes vitamins. So when you have liver disease, especially the more progressive that disease gets, you have more impaired synthesis of vitamins such as thiamine and vitamin D. You have impaired activation of vitamin D and zinc, and impaired storage of vitamin A and folic acid. In addition to that, for liver disease, depending on the etiology, if you have primary biliary cholangitis or primary sclerosing cholangitis, so impacting the gallbladder, you might have decreased bile production from prolonged cholestasis, so that increases your risk of fat-soluble vitamin deficiency as well. For patients who have liver disease as a result of alcoholism or who are continuing to have high alcohol use, this decreases intestinal absorption of vitamins such as thiamine, folic acid, and mineral zinc. Impaired renal reabsorption and increased excretion of thiamine and folic acid also occurs with alcohol use, as well as impaired release of vitamin B12 from proteins that you're taking in via food, and impaired B6 metabolism as well. Therapies that we commonly see for patients with liver disease include, for example, my case patient, lactulose therapy. Patients may require diuretics if they're fluid overloaded or have edema, cholestyramine, and then excessive zinc supplementation is typically only seen in patients with Wilson disease. So coming back to some of those therapies that I mentioned on the previous slides, diuretic therapy is very common in the hospital setting, not only for transplant patients, but for any patient who is fluid overloaded. This increases loss of thiamine, and I've seen some studies that indicate that it's possibly dose dependent, especially long term. So therapies or diuretics lasting longer than 6 months, especially in the CHF population, up to 90–97% of those patients may become thiamine deficient in that long-term diuretic use phase. And diuretics may also increase zinc excretion in the urine. So these are micronutrients that if one of my patients are on diuretics, especially for increased doses and longer durations of time, I kind of hone in on those 2 micronutrients specifically to look at if we need to start some supplementation. Who require renal replacement therapy have increased losses of vitamin A, D, thiamine, B6, folic acid, B12, and vitamin C. because CRT increases the clearance of many of these vitamins and minerals. Unfortunately, we don't have great data on the amount of each micronutrient that's lost in the effluent from CVVH, so there's no specific supplementation recommendations for renal replacement therapy. In terms of lactulose, this can increase your loss of zinc, potassium, and magnesium in the stool as it increases stool output. Cholestyramine is something that binds to bile acids and might cause malabsorption of fat and fat-soluble vitamins, and may also impair folic acid and iron absorption. And then excessive zinc supplementation in Wilson's disease, as I mentioned, these two kind of compete for absorption sites. So if both therapies are given enterally, this is something that you might see a copper deficiency manifest. I do have references here too, so if you want any more information specifically on studies trying to look at the amount of losses of each of these micronutrients through these therapies, those might provide a little bit more information. And then for our post-transplant patients who are receiving immunosuppressive medications, these are some of the categories of those medications and their potential impact on micronutrient status as well. So for patients requiring calcineurin inhibitors, so that's typically Prograf or cyclosporine, you're going to see increased magnesium losses, and that's due to the reabsorption of magnesium from the renal tubules. Patients on Cellcept, Myfortic, you might see interaction with mineral supplements like magnesium, calcium, and iron, and those can decrease absorption of that medication. So typically these have to be separated by several hours. And then patients requiring glucocorticoids, you're going to see decreased levels of vitamin D and phosphorus. And then also calcium absorption is decreased as well. So coming back to my case, he definitely has risk factors for micronutrient deficiency. I've highlighted those on the slides here. So just the fact that he has end-stage liver disease is a risk factor for micronutrients because of the liver's role in micronutrient metabolism. His alcohol use increases his risk for many micronutrient deficiencies, as we've talked about. The fact that he has altered mental status might impair his ability to take in adequate nutrition, stating that he wasn't even sure that his lunch was at the table. And his medication of lactulose, which might increase stool output, puts him at high risk for micronutrient deficiency as well. So then moving on to evaluation of micronutrient deficiency, things that I include in a more in-depth evaluation, especially if the patient's not able to give me intake or weight history. So this is something that I hear quite a bit, especially in my role as a trainer for the academy. I did a nutrition-focused physical exam, but only for fat and muscle. And that's something that we've really focused on, especially at my hospital, is, your physical exam is not just fat and muscle. It has to include all the components. And I actually I'm starting to call it a nutrition-focused physical exam plus. And the plus to me stands for those things that you can't quite see, but they are signs and symptoms of micronutrient deficiency that we can't overlook. So I'm going to skip over the fat and muscle part, but then examining the hair, eyes, mouth, skin, and nails can definitely cue you in as to micronutrient deficiency. And again, once it's hitting that physical manner, that patient has had a physiologic deficiency for quite a long time. That plus then is going to be things like cognitive impairment, poor muscle control, muscle pain and cramps. I ask if my patients have tingling or numbness in their hands or extremities. If you're seeing patients with bone fractures or osteoporosis, and even heart failure and tachycardia can be indications of micronutrient deficiency as well. So these are things that maybe I don't evaluate for personally, but I definitely watch for those in my chart review. And I always think, is there a nutrition reason that this could be caused? Knowing that there's many medical and medication reasons as well that these things could be occurring. Moving on to the lab draw, this is always a question that you want to ask is it time to draw a lab? Should we check a lab? Is that going to help? And one of the things that I encounter in the inpatient side especially is stress-related micronutrient redistribution. So as a response to stress, some of these micronutrients are redistributed due to the pro-inflammatory release of cytokines. So that means that they're either moving into or out of the circulating compartments, and that's going to affect that lab draw. So some of those serum concentrations are going to be altered due to the stress response and not due to the whole body stores of those micronutrients. So I've kind of listed these on the page here. Most of your micronutrients are going to have a decrease in the serum levels, but copper and chromium are the two that you might see an increase because those have a positive response to the inflammatory response. In terms of interpreting serum values during stress, some of the things that you can do, and there are recommendations, is to interpret them in conjunction with an indicator of inflammatory status. So that decrease in serum concentration might be proportionate to the magnitude of inflammation, but we still don't have great data to say exactly how much. And there's no universal approach for how to account for inflammation. Some of the things you might be able to look at include C-reactive protein, and I've listed the categories of minor, moderate, and major inflammation. But typically, and especially at my hospital, there's a focus on not ordering extra labs all the time for these purposes. So I always think about, is there another way that we can gauge inflammation without ordering another lab? And if you think about it, we're always assessing for the inflammatory status when we look at subjective global assessment, when we look at the Aspen and AND criteria for malnutrition, because these are in the context of acute, chronic, and non-inflammatory illnesses. And it's also included in the GLIM criteria if anybody's using that as well. So coming back to our case, this patient's signs and symptoms of micronutrient deficiency may include lactic acidosis. On physical exam, I did notice a white or gray foamy lesion on the inner left eye. He obviously had altered mental status, and when I had him move his eyes back and forth, he had nystagmus, which is ocular motor dysfunction. So based on these risk factors and clinical suspicions, I checked a vitamin D level and a vitamin A level and found that those were both very low. Now, if he does have any inflammation present, I think these levels are actually too low to say that inflammation is the only reason that these are low. So I did have a high clinical suspicion for thiamine deficiency based on lactic acidosis, altered mental status, and nystagmus, and confirmed vitamin A deficiency and vitamin D deficiency with labs, as well as the physical findings. So then the next step, of course, is what do you do about it? So how do you provide supplementation for these patients once you have a suspected or confirmed deficiency? First, you have to figure out which route you want to provide it through, how much you want to give and for how long, and then figure out what you're going to do after that is complete. So if you are thinking about providing micronutrient supplementation through the oral or enteral route, depending on what your patient is able to do, you want to consider anatomy. So if your patient has had a previous resection of any of these GI segments, or they have a gastric bypass, or they have inflammation, Crohn's disease, something like that, this is a table that I actually keep at my desk, and I kind of look at what each of these sites are responsible for. So if my patient had an ileal resection at some point, I know that they're going to have decreased capacity or ability to absorb vitamin C, folate, vitamin B12, vitamin D, so on and so forth. And then there are indications then for IV supplementation. So again, if you suspect that your patient is going to absorb the micronutrients that you're providing enterally or orally, that would be a reason to provide IV supplementation. This is a great paper that was published in 2019 by Aspen talking about IV supplementation of micronutrients and various clinical scenarios where that would be beneficial. So I'm just going to suggest that you take a look at this paper if you haven't read it already. Then I'll quickly go through, this is a paper that I published last year on micronutrient supplementation for end-stage liver disease patients. And it kind of goes through all of the different micronutrients in terms of what are your risk factors for deficiency, what are those signs and symptoms specifically, because we didn't get a chance to go through those in detail in today's talk. Laboratory values to look for, and then repletion recommendations and strategies. You're going to notice in all of these tables that there's sometimes a wide range of supplementation, and this is something that you're going to have to essentially pick a dose within that range and monitor appropriately. For us too, it kind of depends on the doses and the concentrations that we have on formulary. So for example, vitamin A, we don't have a 2,000 international unit dose. We only have increments of 8,000s. So that's a limitation that I have within my own institution, for example. So this is your water-soluble vitamins. An example when you're really thinking about oral or IV therapy, something that I have to consider every day for my patients is thiamine. So thiamine is very poorly bioavailable through the enteral tract. For example, you only absorb about 4.5 milligrams of a 30 milligram dose of thiamine, and that does not get better the more thiamine you give enterally. So for patients who have alcohol use disorders or who have suspected or confirmed Wernicke's encephalopathy, or they're just at very high risk for thiamine deficiency, these are the patients that I'm supplementing intravenously. This paper, there was a paper written, I think it was in 2018, don't quote me on that. It's called Unpeeling the Evidence of the Banana Bag. It really talks about thiamine supplementation, and highly recommend that article. And then here are supplementation recommendations for some of the micronutrients, some of the trace elements, including zinc, selenium, and copper. Again, I'm not going to go through these for the just for time's sake. So then coming back to the case, because he had high clinical suspicion for thiamine deficiency and a confirmed vitamin A and D deficiency, what we did for him because of his alcohol use disorder was we have something called a CPEU banana bag, again, based off of that article that I had mentioned. So we give a total of 10 mils of a multi-dose, 1,000 milligrams of thiamine daily. This is divided into 1 milligram of folic acid and then 4 milligrams of magnesium sulfate, because magnesium is required to sufficiently utilize thiamine. So we give these for 5 days total, over 10 doses, and then we switch to oral supplementation. And then this patient also received vitamin D2, 50,000 units weekly for 8 weeks, as well as vitamin A. Again, we only have increments of 8,000 units at my hospital, so we gave 16,000 units daily for 8 weeks, and then we recheck those levels, or at least that was the plan. So some of my last thoughts on supplementation then is, again, have a follow-up plan. So for my patient, if we're supplementing for 8 weeks and he's no longer in the hospital, I might have to send a message through our electronic health record to follow up on an outpatient basis, or if they're still inpatient, kind of set a reminder for myself to do that. Adjusting the timing of supplementation to avoid drug nutrient and nutrient-nutrient interactions. Sometimes this happens, you know, for if there's a medication that's timed, we just kind of have to work with our pharmacist to make sure that there's going to be no interactions. A lot of my patients become NPO due to unsafe or mental status. So if they're receiving, you know, fat-soluble vitamin supplementation, but they have no enteral fat source, I might actually pause that supplementation until they do have the enteral fat source, and then making sure that they have medications to support fat absorption as well is going to be important. And then the last thing I try to think about for my patients is pill burden. So a lot of these patients are on a lot of medications, and I know that their micronutrient supplementation adds to that. So I try to be very familiar with the micronutrient products that are available on our formulary and condense as much as possible to kind of reduce that pill burden. So in summary, for my portion of the talk, definitely evaluate for possible micronutrient deficiency in all of your transplant patients with end-stage organ failures. Make sure that you have timely identification and supplementation to correct micronutrient deficiencies before they result in worse complications. And then more research, of course, is needed to identify optimal vitamin and mineral dosing in various disease states, as well as different therapies such as CRRT, and using different immunosuppression regimens. So I hope to see that in the future.
Thank you, Michelle, and thank you, Dr. Hasse, for an excellent and timely presentation. I think we have just a few moments for a couple of questions. So, Jeanette, the first question that I have for you is, any recommendations on how do you assess if the fluid accumulation criteria for malnutrition is from nutrition or from the disease state?
I think it's probably difficult to discern it completely, and I went back and I looked at these consensus criteria in a follow-up paper by Ainsley Malone. In that paper, they actually state, and I'm quoting, discerning fluid accumulation due to malnutrition will be difficult. So I think the intent was that fluid accumulation was supposed to be due to malnutrition, but practically when I look at the criteria and we have to choose 2 out of the 6 criteria, I often find that patients who already have ascites or edema meet these other criteria. I'm usually working with patients who have malnutrition in the context of critical illness. So that low energy intake usually qualifies. Physical findings of low muscle mass or low fat mass would also qualify. And then if you happen to be measuring grip strength. So I usually can find 2 criteria without even having to consider fluid retention.
Great. Thank you very much, Dr. Hasse. Okay, I think the next question that we'll have time for today, Michelle, if vitamin A and zinc are elevated in a pre-dialysis end-stage renal disease patient due to reduced excretion, how would you suggest correcting for this?
That is something that's a difficult question, because I don't think there is any therapies that I know of that can really reduce those levels per se, but what I will do is focus on what am I providing to the patient. So I might evaluate the micronutrient composition of the enteral formula I'm providing, or the multivitamin that I'm providing. I know that we have about 6 or 7 different multivitamin products on formulary, so I'll actually go and look at the individual composition of each of those to make sure that I'm not supplementing additional vitamin A or zinc for patients who have elevated levels.
Great, thank you. And thank you again, Dr. Hasse and Michelle, for an extremely informative presentation. So on behalf of the Nestle Nutrition Institute, we hope that you found this information useful to your practice and enjoy the rest of your day. Thank you.